Hi, I'm Daniel Wong from Stanford Endourology. Today I'm presenting STIM, our investigation of whether ADHD stimulant medications increase the risk of incident kidney stones. In almost 48,000 new users of ADHD medications, stimulant users had a 34% higher hazard of kidney stones than non-stimulant users. The signal was driven mostly by amphetamines and stayed consistent across multiple sensitivity analyses. The full analysis was built end-to-end on Medeloop in a single afternoon. The reason this question matters is that two common clinical problems are intersecting. More than 6 million U.S. children and adolescents have an ADHD diagnosis. Stimulant prescribing has been rising, and kidney stones account for roughly 10 million emergency department visits each year. Stimulants are sympathomimetic. They can raise blood pressure, suppress appetite, and reduce fluid intake. All plausible routes towards stone formation. Yet the field has lacked a rigorous active comparator claim study testing whether stimulants actually raise stone risk. We approach this as a target trial emulation in Health Verity claims data from January 2020 through June 2025. Patients needed an ADHD diagnosis, a 6-month medication-free washout, and at least 90 days of medication supply. We excluded anyone with a prevalent kidney stone in the prior year. The exposure was stimulant versus non-stimulant ADHD medication, and the outcome was an incident kidney stone diagnosis or procedure. We used as-treated follow-up, stabilized IPTW across 11 baseline covariates, and a weighted Cox model with robust standard errors. Here is the cohort. We started with 230,448 patients with an ADHD diagnosis. After excluding prevalent stones, prior medication exposure, and inadequate enrollment, 47,982 patients met the 90-day supply minimum. The final cohort was about 4-to-1, 38,175 stimulant users and 9,807 non-stimulant users. There were 400 incident kidney stone events across nearly 51,000 person-years. After weighting, all 11 measured covariates were extremely well balanced. The primary result is the center of the study. In the IPTW weighted Cox model, the hazard ratio was 1.34, with a 95% confidence interval from 1.00 to 1.80, and a p-value of 0.0495. The unadjusted and multivariable adjusted models were nearly identical, which supports the stability of the finding. This is clinically meaningful at population scale, but it should still be interpreted as hypothesis generating because the lower confidence bound just touches 1. The molecule-level result is the most actionable part. Amphetamine users had 10.2 stones per 1,000 person-years, more than double the methylphenidate rate of 4.62, with a hazard ratio of 2.23. Lisdexamphetamine, a dextroamphetamine prodrug, showed a similar pattern at 9.12 per 1,000 person-years and a hazard ratio of 1.97. Methylphenidate was the largest stimulant subgroup and the lowest risk one, suggesting it may be preferable for patients with elevated baseline stone risk. We then stress-tested the signal. Excluding clonidine, which carries its own blood pressure confounding, strengthened the estimate to a hazard ratio of 1.48. Restricting outcomes to procedure-confirmed stones preserved the effect size at 1.44, with p just above 0.05. The intention to treat analysis attenuated to 1.09. That is expected because non-stimulant users switched medications more often. And under intention to treat, switching dilutes the on-treatment exposure contrast. So, the takeaways are straightforward. First, new users of stimulant ADHD medications had a 34% higher hazard of incident kidney stones than non-stimulant initiators. Second, the excess risk was concentrated in amphetamine and lisdexamphetamine, while methylphenidate sat at the bottom. Third, the signal held up across sensitivity analyses. If confirmed prospectively, methylphenidate may be the preferred first-line stimulant for ADHD patients with a personal or family history of urolithiasis, and the complete workflow, from cohort construction through modeling and figures, ran end-to-end on Medeloop.